Thank you so much, you guys, for coming and joining us on this presentation tonight on such a beautiful night in Minnesota. It's just gorgeous here. I saw, when I was waiting, I saw some people in the chat box from New York, from Washington, Ohio, Wisconsin. I hope it's nice there. And I hope if it's nice out, you're enjoying this outside. And before I get started, I want to make sure I kind of threw Joe a curveball, and I emailed some handouts to her earlier today. So you should have received another email that has some handouts from me. There's going to be 3 pieces of information on that. One is some links with some HPV resources. There's going to be some motivational interviewing resources. At the end of this presentation, Professor Michelle Arnett and I are going to do some role play for you. And so there's the script for that. And there's also some other scripts that you might be able to use when you're talking to your patients about HPV. So thank you so much again for joining me. This is a topic that's I'm very passionate about. I believe that we all have a very important role in preventing HPV. And not just HPV oropharyngeal cancer, but all cancers that are associated with HPV. I don't think that any of us, when we were signing up to be a dental provider, thought that someday we would be talking to our patients about a sexually transmitted infection, but here we are. So hopefully the presentation tonight will help you become a little more knowledgeable, maybe a little more comfortable in talking to your patients about HPV, because I think one of the things is the first step is really educating ourselves so that we do feel comfortable in talking to our patients. So let's go ahead and dig in. So HPV is the most common sexually transmitted infection in the United States. It's highly communicable. 80 to 90% of all sexually active men and women will be infected with at least one type of HPV in their lifetime. And 50% of those will be high risk type. And we'll talk about high risk and low risk types in a little bit. There are 14 million new genital HPV infections each year. Most HPV infections, though, are asymptomatic, so people don't know they have it. And this is when it's spread. It can be spread even when an affected person has no symptoms. Does this remind anybody of a virus we're thinking about these days? So a lot of similarities between the HPV virus and COVID. But HPV can be spread through skin-to-skin contact. There does not have to be any intercourse for that for that HPV transmission. HPV-associated diseases have really created a significant economic burden to the society. Yet, at the same time, there's a vaccine that's been available since 2006. And it's been shown to be safe and effective. And you guys, it's the only vaccine available that prevents cancer. But even despite all that, the vaccination rates are well below national goals. One of the strategies to increase vaccine uptake is to educate healthcare providers like you so that you feel more comfortable in talking about an STI with your patients and give you the confidence to give strong recommendations for the vaccine. And with the connection between HPV and oropharyngeal cancer, it really is our duty to, as dental providers, to become involved in the prevention of oropharyngeal cancer, both by educating ourselves first and then by educating our patients regarding the connection between oropharyngeal cancer and the human papillomavirus, and to become advocates for the vaccine. So hopefully this presentation will provide you with the basic facts that you need to feel comfortable in talking about HPV and oropharyngeal cancer. We'll talk a little bit about the HPV vaccine, and we'll offer recommendations for the role of the dental provider in HPV prevention. So oral and oropharyngeal cancers are often grouped together under the broad term oral cancer. However, in recent years, it's become apparent that there are really two distinct epidemiologic differences between cancers of the oral cavity and cancers of the oropharyngeal area. The overall incidence of head and neck cancers is declining, which is great news, and in part thanks to all of you for your tobacco cessation activities in the dental office. But it really depends on the risk factor and the anatomic location. 150% decrease has been experienced over the last decade or so in HPV negative cancers. So those oral cancers that are related to smoking and alcohol related oral cancers. But at the same time, there's been a 225% increase in HPV positive oropharyngeal cancer. Excuse me. There's also been a change in demographics. So historically, as you know, with smoking and alcohol-related cancers, the individuals who were most at risk were older Black males from lower social economic status. However, with HPV-related oropharyngeal cancer, the individuals most at risk are younger white males from higher SES. And we've also noticed a bimodal incidence with two peaks, one at around age 35 and one at around age 55. And although women do get oropharyngeal cancer, men are about 3 times more likely than women to be diagnosed with HPV-related oropharyngeal cancer. 70 to 80% of oropharyngeal squamous cell carcinomas are caused by HPV in the United States. Cervical cancer was once the #1 HPV attributed cancer, but those rates are declining with effective screening tests and the vaccine. But at the same time, with the rates of oropharyngeal cancer increasing, oropharyngeal cancer is now the #1 HPV attributable cancer. So briefly, HPV are small, non-enveloped, double-stranded DNA viruses. And just very quickly, the role of DNA in viruses is long-term storage of information. There are more than 200 known types of HPV, and they're divided into 2 categories: low-risk types and high-risk types. The low-risk types are those that affect cutaneous surfaces, so things like common warts or genital warts, respiratory papillomas. These low-risk types very often have no symptoms. You don't even know that you're infected with it, and they're cleared by the immune system within a couple years. The high-risk types are those that affect the moist mucosal surfaces of the body, and these are the types that lead to cancer. The 2 most common types of oncogenic HPV strains are 16 and 18. And these are the 2 that are cause most cases of oropharyngeal cancer. So other than cancer, some of the clinical manifestations, like I mentioned, can include anogenital warts, common skin warts, and then recurrent respiratory papillomatosis, as well as polyps on the vocal cords. You may have heard someone say they have nodes on their vocal cords. Those are all caused by HPV. Only 5% of people infected with HPV will get cancer. The types that, again, are responsible are, for 70% of all HPV-related cancers are types 16 and 18. The virus has been known to persist up to 20 and even 30 years with no symptoms. So this makes it really difficult to know when the virus was contracted, and no way to know if the infection will develop into cancer. However, we do know that most of these infections are contracted during the teens and 20s during risky sexual behavior. While there are other cancers associated with HPV, these are the top 6 cancers that are attributed to HPV with the yearly number of cases in the United States. You can see here that oropharyngeal cancer has now outpaced cervical cancer. So there is no cure for HPV for those viruses that have not cleared. But again, most infections are cleared within 2 years. However, the clinical manifestations can be treated. So for example, for warts, there's creams and pills. And then for cancer, surgery, radiotherapy, or chemotherapy. So because of this, the key really is to prevent the infection. And really, abstinence is the only absolute prevention for any STI. But the risk of any sexually related infection can be lowered by following certain practices. Again, most infections occur during adolescence and into the 20s. So delaying sexual contact until an older age, being in a monogamous relationship, can lower a person's risk. Also, research has shown that using condoms or dental dams during oral sex have shown to reduce transmission. And of course, vaccination. Vaccination has been found to prevent 90% of all HPV positive cancers. There are 3 different vaccines available that are effective against some type of HPV, but they're not effective against all, 200 plus types. But in the United States, the only one available now and used is the 9-valent. The 9-valent is effective against both high risk and low risk types. And you'll recognize here that both 16 and 18 are in the 9-valent vaccine. So that this vaccine is effective against the types that are known to cause cancer in oropharyngeal cancer. Also, the 2 most common low risk types are type 6 and 11. So the vaccine has been found to be safe and effective in several clinical trials, and both the CDC and the FDA continue to monitor the vaccine as it's being used. We also know that in the 10 plus years since it has been offered, that immunogenicity has not waned. So they're thinking that they may not need a booster vaccine at some point. So you'll see the words approved and recommended used when you read about the vaccine, and this can be confusing. So I'll try to clear that up a little bit here. It's not the same thing. So there's 2 different agencies that give both recommendations and approvals for the vaccine. That's the FDA. The FDA approves the vaccine for safe use and that it's approved, the efficacy is approved as well. And the CDC, the Advisory Committee on Immunization Practices, is the organization that recommends who should receive the vaccine and when. So the vaccine is most effective when the individual is younger, when the immune response is stronger, and before a sexual debut. So this is the reason it's recommended for 11 to 12-year-olds. It's really most effective between those ages. Even so, they recommend everyone up to age 26 get the vaccine. And in looking at the dates here, you can see that unfortunately there was a 2-year lag between when the FDA approved boys to get the vaccine and when the ACIP recommended it for boys. So we have that whole cohort of boys that may have missed out on that vaccine. So we may see this have an effect on the number of oropharyngeal cases in the future. I also want to point out that in 2018, the FDA approved the vaccine for adults up to age 45. Now, the CDC wasn't quite on board with it right away. However, they're sort of on board now. What the ACIP recommends is that for anyone between the ages of 27 and 45, that administration is really done through a shared decision-making process between the patient and the physician. And this would be based on the patient's risk factors and the benefits of the vaccine. It's not recommended for all adults in this age range because it really is not cost-effective. The dosing schedule for the 9-valent vaccine is a 2-dose schedule if it's given before the age of 15. And these doses are given at least 6 months apart. For those individuals over age 15, the dosing schedule is 3 doses, with the second dose being at 1 to 2 months after the first dose, and the third dose 6 months after the first dose. You will hear me use throughout this presentation the term up to date. An individual is considered up to date if they have received the recommended doses, whether or not that's the 2-dose schedule or the 3-dose schedule. As I said earlier, the vaccine has been found to be safe and effective in multiple studies. Over 100 million doses have been distributed in the United States since it was licensed, with very, very few, very few incidents of any adverse outcome. Just this month, the ADA published an umbrella review of HPV vaccination in the JADA issue of April. The authors looked only at systematic reviews of HPV vaccines, and then they synthesized all of those findings from the systematic reviews into one document, so that dental providers are able to use that in practice. And the purpose was to look at the evidence behind the efficacy, effectiveness, and safety of the HPV vaccine. So this paper really provides the best available evidence on HPV, and I recommend using it. I have listed it in the reference section at the end of my slides. But what their review showed is that if there were any adverse events, which there were very few, it's usually a local event, such as pain, swelling, or redness at the injection site. And this is something that's experienced with any vaccination. If there were any systemic reviews or systemic events reported, these would include fever, headache, and fatigue, nothing more serious than that. And again, there were very few of those. There were no deaths or negative pregnancy outcomes reported. Now, having said that, although there's no adverse pregnancy outcomes, pregnant women should wait. If they know they're pregnant, they should wait to get the vaccine. Also, individuals who are acutely ill should wait until they're better, and this is true for any vaccination. Also, sometimes the vaccine comes in pre-filled syringes that may contain latex, so that's something to be aware of as well. Since 2006, when the vaccine was first made available, there's been a 71% decrease in HPV infections in adolescent girls, including an 83% reduction in type 16 and 18. So that's really good news. This chart here shows the vaccine efficacy outcomes from the JADA study. You can see that only one systematic review showed that there was no evidence of benefit related to the prevention of precancerous lesions. But the collective evidence from the systematic reviews of randomized control trials show that HPV vaccines are effective against the vaccine type HPVs and the associated changes, including precancerous and benign lesions. So it's important to dental professionals, though, that although none of the studies included in the systematic reviews investigated the effect on oral infections, the vaccine has been shown to be effective against the types that are associated with oropharyngeal cancer. And in 2017, a study was published where the researchers analyzed data from the National Health and Nutrition Examination Survey between the years of 2011 and 2014. They focused on 18 to 33-year-old men and women because they were the first group during that time period to receive the vaccine. From these participants, they took mouth rinse samples and analyzed them for the vaccine types 6, 11, 16, and 18. They found that there was an 88% reduction in those who were vaccinated compared to those who were not vaccinated. Additionally, there was a study done in Costa Rica. It's a 4-year study that investigated the effectiveness of the vaccine. And they looked at vaccine multi-site effectiveness. So in other words, if the vaccine was effective against a vaginal infection, was it also effective against an oral infection? And they found that there was a 93% efficacy against oral HPV infections in that study. This graph shows HPV vaccination rates compared to meningococcal and Tdap, and you can see that the rates are much lower than other childhood vaccinations. The good news is that you can see that the rates are increasing. However, during this time period, the increase was mostly attributable to the increase in the number of males receiving the vaccine. Because if you remember, 2011 was when the ACIP finally came out and recommended it for males. However, this is great news when we're considering the potential for prevention of oropharyngeal cancer. But you can see that the vaccination rates are low, especially when compared to the Healthy People 2020 goal of 80%. In 2018, the national rate of up-to-date vaccination status was 51.1 for teens between the ages of 13 and 17, with 68% having received 1 dose. Now remember, the series is a 2 or 3 dose, depending on the age of initiation. Now let's look at Minnesota. There's 2 agencies who report vaccination rates for Minnesota, the CDC and the Minnesota Department of Health. The CDC, they use different sets of data to get their vaccination rates. So the CDC uses the National Immunization Survey, which shows that Minnesota, for adolescents aged 13 to 17, that the Minnesota rate was 58.1%. Were up to date on the HPV vaccine. MDH uses the Minnesota Immunization Information Connection, which you can see there shows a much lower rate, 38.7%. Now, again, these 2 rates are calculated differently. The NIS data, or the CDC data, is collected through a random sample of phone interviews with parents, and that information is checked against provider vaccination records. The MIIC gets data from a voluntary provider reporting program. So, you know, it may not be all that accurate, although MDH reports that, you know, the majority of providers do report vaccinations. So either way, we fall well below the Healthy People 2020 goal. So while there are a number of reasons why parents decide not to vaccinate their children against HPV, both national and state data show that provider recommendation is really key to vaccine uptake. Those that have not vaccinated their children report that they never received a recommendation from their provider. Other factors include the parents don't know about the vaccine. They may be concerned about the safety and efficacy of the vaccine. And, you know, they lack the perceived risk of their children. I mean, we're talking about 11 and 12-year-olds here. What parent's going to think their child is, you know, susceptible to an STI? So really, it's just all about educating the parents. And then we need to remember that we shouldn't just be talking to parents of children. We should also be talking to adults, because there are many who have never received the vaccine. And the most common barrier for that age group, for the 18 to 26-year-olds, is the lack of perceived risk as well. So now let's focus on oral HPV infections. There are about 15,000 cases of oropharyngeal cancer diagnosed each year. And if you think about it, that's, you know, between 250 and 300 cases a week. But that's a lot of cases that we could be preventing. There are about 19 high-risk types that have been found in the head and neck region, but again, 16 and 18 cause most of the cancer. However, about 80% of all oral HPV, including 16 and 18, are cleared by the immune system. We have an incredible immune system. HPV infects the epithelial cells of the oral pharynx, and the most common sites that are affected include the lingual and palatine tonsils, the base of the tongue, the anterior surface of the soft palate, the uvula, lateral and posterior pharyngeal walls, and the glossotonsillar sulcus. This is a more close-up drawing of the oral pharyngeal area. And you can see here that the base of the tongue is the part that is behind the circumvallate papilla. There's several risk factors for oral HPV infection. Of course, as you might imagine, most of them have to do with sexual risk factors. In the past few decades, we have seen a decrease in the age of sexual debut and an increase in the number of sexual partners. Additionally, we've seen an increase in the younger population engaging in oral sex with multiple partners. The risk increases 5-fold for those patients with 6 or more oral sex partners compared to those who have not had oral sex when we're talking about oral cancer, oral pharyngeal cancer. What really makes it so infectious, again, is because most HPV infections have no symptoms and a person has no idea they've been infected. And there's generally no way, again, to know when a person was infected or by whom. We also know that there is a high prevalence of oral infections in individuals who have genital infections. So, and this is true for both men and women. So what this means is that for those individuals with a genital infection, they are more likely to also have an oral HPV infection. And experts think that this is because the virus is spread from genital to oral sites through contaminated fingernails. For those who are already infected with HPV, there are factors that increase the risk of oral pharyngeal cancer and reduce the outcomes of cancer treatment. And you can see, looking at this list, that these risk factors are really all risk factors affecting the immune system. I do want to make a comment about ill-fitting, unclean dentures. So several studies have shown that mucosal injuries caused by ill-fitting dentures and poor oral hygiene due to unclean dentures have been found to be a risk factor in HPV infection. And one study showed that HPV is co-localized in biofilm when looking at tonsillar crypts. And so the researchers think that this may play a role in the pathogenesis of HPV-related oral pharyngeal cancer. Again, like I said earlier, oral pharyngeal cancer rates are 3 times higher in men than women. And they think that this is because women develop protective antibodies to HPV after having just a few sexual partners. But for men, it may take more than 10 partners. And the reason for this is that in women, the infection is vaginal mucosal. In men, it's entirely on the skin, where it's much less likely to trigger an antibody response. So males can get an active infection again and again, and it lingers longer than in women. This chart shows the rates of oral pharyngeal cancer in each state. You'll see here that Minnesota is one of the lower states with lower rates. And I want to point out, if you look at Iowa, that it has one of the lowest rates in the country. And in my mind, not coincidentally, in Iowa, the vaccination rates are at 94%. These graphs show a comparison of the incidence of oral and oral pharyngeal cancer by age groups. So on the left, you will see oral cancer, and you can see that the incidence rate is peaks in the late 60s and 70s, whereas oropharyngeal cancer affects individuals about 10 years earlier than that. So, as I've stated several times, most cases of HPV infection are asymptomatic. But there are symptoms, but they may not show up for decades until the virus has converted. And so it's important for us to understand what these signs and symptoms are once that conversion has happened. The most frequent presentation of HPV positive oropharyngeal cancer is metastatic cervical swelling. The patient may have noticed, they may come in and they say, oh, I've had this, this lump in my neck and it's just getting bigger and bigger, pretty quickly. Or they may complain that they have just persistent swallowing difficulty. They may have a hoarse voice. Their voice may have changed. They may have throat pain. They may even have noticed some bleeding in their throat. Also, ear or jaw pain is another symptom. The patient may also have experienced some rapid weight loss over the last several months. And when you're performing your oral exam, you may notice that another sign that's very important is that the palatine or lingual tonsils may not be symmetrical. So that's one thing you need to look at when you're doing your exam. So because of the long latency period and because of the lack of symptoms in early disease, it's hard for us to even know the patient has oropharyngeal cancer. So for this reason, that's generally diagnosed at later stages when it's already metastasized. Additionally, there's no recommended screening test because there's no precursor lesion as there is for cervical cancer. And there's no equivalent screening test to the Pap test for oropharyngeal precancers. And this is mostly because of the location of the cancers. It's very difficult, if not impossible, to get tissue samples from the tonsils and the base of the tongue. I want to mention that there is HPV testing through rinsing. You may have heard about this. And I want to caution you on this because although a negative test eliminates the risk of the development of cancerous lesions, a positive test can simply reflect a transient infection. So the presence of HPV 16 or 18 in the mouth does not mean the patient will develop cancer. We do know, however, that the presence of HPV 16 in the oral cavity precedes the development of oropharyngeal cancer. However, even having said that, most of those infections will be cleared. And there's really no way for us to determine whether or not the infection will persist. So for this reason, routine screening for HPV 16 in oral rinses has not really been shown to be an effective screening tool. And honestly, if a patient did have HPV 16, because we don't really know what that progression is going to be and the body may clear it, I wouldn't want to cause any emotional distress with my patient. So that's another reason we may want to be cautioned on using that just alone. You may want to use it with some other tools, but not just a rinse. The good news is, though, that HPV-related oropharyngeal cancers show improved prognosis over non-HPV-related oral cancers. And this is due to several factors. Generally, because the patient is diagnosed at a younger age, they've been exposed, they have a lack of exposure to carcinogens such as tobacco and alcohol. They're healthy, so they have the absence of comorbidities. And they have an improved response to treatment and survival. However, if the patient smokes, this does negatively impact the prognosis. And there's a 30% recurrence rate within 1 year. And I wanted to show you this picture of Jason Mendelson. He's known as Superman HPV. He has a website. And he was 44 years old when he was diagnosed with stage 4 throat cancer. Good news is he's made a full recovery, but he really has made HPV awareness sort of his life mission. He has an excellent website. I would encourage any of you to go to the website. He also speaks across the nation, and he's even spoken to Congress on HPV prevention. So I encourage you to check out his website. When a patient has been diagnosed with HPV oropharyngeal cancer, the staging and the treatment are the same as other oral cancers. However, because the response to treatment is improved, most of the treatment protocol is de-escalated from what typical treatment plans might be for other oral cancers. This reduces side effects while maintaining the good outcomes. So depending on the stage of cancer, treatment may include surgery or radiation, chemotherapy, but in reality, it's probably going to be a combination of all of them. With improvements in less invasive surgeries, this has really become the preference because there's lower morbidity, more side effects associated with surgery than with radiation and chemotherapy. However, even with the de-escalation of the treatment protocols, patients do still experience mucositis and other side effects, including weight loss. And I did want to point out that the financial burden of these cancers is great. The estimated cost to treat a patient in the first 2 years following diagnosis is $140,000. And, although mortality is improved, the morbidity from treatment can be substantial and life-altering. It can affect speech, swallowing, airway patency, dry mouth, loss of taste, TMJ dysfunction, osteoradionecrosis, and even progression of some dental disease. Some patients will require gastrostomy tubes for nutritional health or tracheostomies for airway maintenance. But as dental providers, you can see that for many of these side effects, we can help our patients manage them. So this leads me to our role. You can see that we have an important role in reducing the morbidity and mortality associated with oral HPV. And there's several ways we can reduce the burden. First, dental providers must educate themselves on the facts so that we can feel confident in talking to our patients about HPV. We are also in a unique position to educate patients and parents to not only prevent, talking to our patients about prevention of HPV infection, but also to talk to our patients about vaccine. The HPV vaccine, and discuss how to go about obtaining the HPV vaccine and the safety and the efficacy of the vaccine. Many patients and parents are not aware of the role of HPV in throat cancer. So, patient education will most often be talking to parents of adolescents. However, I want to mention that there are many adults who are at risk for HPV infection who've never received the vaccine for various reasons. So we want to make sure we're also including young adults in our conversations. And many adult patients, especially adolescents, see their dentist more often than their physician. The 2-dose series aligns with 6-month checkups. So it's a perfect opportunity to talk to your patient about them. And if they've started the vaccine series and we know that, just to remind them that they're due for the second or third dose. Once you have initiated a conversation with your patient about HPV and vaccination, it's essential that you follow up at those recall appointments. And then secondary prevention efforts focus on screening through both the physical head and neck exam and through conducting a thorough medical history. Knowing the risk factors of HPV oropharyngeal cancer is important so that you can talk to your patients about them and then add those risk factors to your medical history form. Early detection really is key to improving prognosis. So although there's no recommended screening tool available for oropharyngeal cancer, looking for those signs, asking your patients questions related to oropharyngeal cancer is going to be important. We need to make sure that we are, along with our intraoral exam, that we're also doing an oropharyngeal exam. And then with tertiary prevention, the goal is to prevent recurrence in our patients who have experienced HPV. And we do this through a thorough head and neck exam, through the medical history, and we can help our patients control the side effects and morbidity associated with the treatments that they've received. We can also collaborate with our patients' other healthcare providers. And tobacco cessation is really an important component of tertiary prevention, and really at all levels of prevention. And finally, even though I said earlier that I wouldn't really recommend HPV 16 salivary rinses as a screening tool, this is the one time where it may be important to use. So for those patients who have already experienced HPV-related cancer, doing the salivary rinses at their appointments may be important for those patients who are in recovery or remission. And although vaccines are not yet delivered by dentists in most states, there are several states that have added vaccine delivery to dentist scope of practice. So recently, Oregon dentists can now administer the HPV vaccine along with other vaccines. Here in Minnesota, dentists can deliver the flu vaccine with training. So my hope is that soon we will, dentists will be approved to administer the HPV vaccine as well. But even so, we can still advocate for the vaccine outside of the operatory. So getting involved with our state associations, starting a campaign with your state association, getting involved with the HPV Roundtable, which is an HPV advocacy national program. Get involved with the Oral Cancer Foundation. And locally in your own practices, establish a pro-vaccine environment. Put up posters and flyers in your office and engage and educate all staff members so all staff members can talk intelligently and competently with our patients about HPV and the vaccine. And then in addition, again, that collaboration with other healthcare professionals to ensure that continuum of care. So when we notice something that we're suspicious about, we can refer patients to their primary care provider for advocacy, or if they don't have a primary care provider, it's important to have a list of community clinics that administer the vaccine on hand so we can refer our patients to those clinics. And then for those patients where we've recognized that there may be something suspicious, we'll want to make sure that we are immediately referring them to either their primary care physician or an ENT for follow-up. I want to point out that the ADA is 100% advocating for visual and tactile exams of not only the oral cavity, but also the oral pharynx. And this news brief was published on October 1st last fall. The ADA House of Delegates passed a resolution that recommends dentists conduct both visual and tactile examination for the early detection of oral and oropharyngeal cancers for all patients, and not just those that we think may be at risk due to tobacco and alcohol. So this means that we really should be doing not only a visual exam of the oropharyngeal area, but also a tactile exam. Early diagnosis is related to improved prognosis, yet there's concern that there's missed opportunities for early referral to ENTs. No one is really screening for oropharyngeal cancer. Most healthy individuals don't go to their primary care physician when they're healthy and when they're feeling well. They tend to only go when they're feeling ill. And of course, generally there's no screening done at those urgent care appointments. So as dental providers, we have a great opportunity to improve early diagnosis and early referral to ENTs by doing our head and neck exams. When you are thinking about oropharyngeal cancer, pay particular attention to the cervical lymph nodes and inform your patient what you're doing. Describe what you're looking for. For example, you could say, I'm looking for any abnormal sores or growths in your mouth and throat. And now I'm going to feel for any swollen lymph nodes in your neck. This is also really a great time to talk to your patient about risk factors for all types of oral and oropharyngeal cancers. And if it makes you more comfortable, you can sort of discuss the risk factors, lump them all together. For example, discussing HPV with other common risk factors such as tobacco and alcohol use. This diagram shows the primary locations of lymph node involvement and the location of the primary tumors. The oropharynx, base of the tongue, the tonsils, generally drain to what are known as level 2 and level 3 lymph nodes, and these are located in the postauricular and deep lateral cervical areas. Infected lymph nodes tend to be firm, tender, enlarged, warm to the touch, and the overlaying skin may even appear red. So when you're doing your oropharyngeal exam, I recommend using a standing operator position, maybe standing in the 8 to 9 o'clock position. And then lay the patient back. Don't lay them back all the way. Lay them back to about 45 degrees. If you lay them back all the way, the tongue falls to the back of the throat, and that makes it harder to visualize that area. And make sure that you're really pulling the cheek and the lips out to give you a good view. You will want to make sure that you are palpating the hard and soft palate. Again, that would probably be with lidocaine spray to stop them from gagging. You also want to palpate the glossotonsillar sulcus. Now, to do this, you will place your finger on the retromolar pad and slide it down into the space between the mandible and the tongue. You will want to have your patient, just like you do for any oral exam, stick out the tongue, have them move it, and observe the tongue for mobility. Visualize and palpate all surfaces of the tongue. When you have the patient say ah, look at their uvula and look for normal movement of the uvula and look for asymmetry. And again, you also want to look for asymmetry in the tonsils too. This picture on this slide is a picture that was taken of the base of the tongue and the epiglottis with a standard intraoral camera. So for those of you who have intraoral cameras, start using them to look at the soft tissue and try and get them back to the oropharyngeal area. And for those patients that are healthy, take a baseline picture so you can use that as a reference point. There are also laryngeal mirrors that are used by ENTs for what's called indirect laryngoscopy. And these mirrors have longer handles and smaller heads, and that helps avoid patient gagging. So you can also purchase one of those to take a look in the oropharyngeal area. But again, you're probably going to want to use some lidocaine spray to get a good view of that area. This table is just some recommendations of questions that you can add to your health and social history form that specifically address HPV. I want to stress that if you see something suspicious or if your patient responds to yes to any of the symptoms, you need to follow them up in 2 weeks. Don't wait for the next recall. Then at the next recall, if you still see something or if they're still experiencing these symptoms, refer them out to an ENT. And then make sure you're following up with those referrals also. One of the most important roles that I think, since we're not really giving the vaccine in our offices, is really just to raise awareness in the prevention of oropharyngeal cancer. While many, again, know about HPV and the role in other cancers, very few people know about its role in oropharyngeal cancer. And many people still don't know that it's available for males. Both the ADA and the AAPD have issued statements in support of dentists advocating for the vaccine. So we have the support of our associations. What I wanted to point out here is that our role in HPV vaccine uptake as dental providers is important even for those people who have heard a recommendation from their medical providers. Not every parent accepts the vaccine for their children the first time their provider recommends it for them. Research shows that when parents hear HPV messages from multiple sources, they are more ready to accept the vaccine. And for those parents who accept the vaccine after initially declining it, the main reasons for accepting it are that they have learned more about the vaccine and that they've heard more about it from multiple providers. So the more we educate our patients about the role of HPV and oropharyngeal cancer, the potential benefits of vaccination, the more effective we become in preventing HPV-related cancers. So we know from all sorts of studies, including a recent ADA survey that was just published in JADA, that dental providers are not really discussing HPV with their patients, and no wonder. I mean, it's embarrassing. It's a difficult topic. It's uncomfortable, and providers have also reported that they just don't know enough about it. And some dental providers have a lack of their perceived role in HPV prevention, and they think it should be left to other healthcare professionals. Also, many practices have an open operatory design, and that really this is sort of a difficult conversation to have when you've got other people and other patients sitting next to you. And some dentists are have even reported that they're worried that they'll be accused of sexual harassment. But for almost all dentists and hygienists and other dental providers, what they're really worried about is, what is our patient going to think if we start talking about a sexually transmitted infection? So I want to tell you about research that we did last August at the Minnesota State Fair. Dr. Elise Sarvis and I conducted research at the Driven to Discover building. If you've never been there, please go. It's amazing. There's hundreds of Minnesota researchers there doing all kinds of great research. And we surveyed parents of children between the ages of 9 and 17 to determine their perceptions on dental providers discussing the HPV with them and their children. And what we found was that they're comfortable. They're very comfortable with it, very receptive to it. And actually, given the information that HPV is associated with throat cancer, they actually expect their dentist to start talking to them about it. And just as a side note, I'm happy to report that I just found out today that this research was accepted for publication in JADA, so be looking for that. Going back to the topic of, should dental providers really be administering the HPV vaccine? One of the questions we used on our State Fair survey was asking parents whether or not they would be comfortable with dentists providing that vaccine during routine dental visits. And again, with children before the age of 15 and those vaccines being 6 months apart, it just fits so nicely with our 6-month recall appointments. But 62% of the parents said that they would be comfortable with it. So that's good news for us. Also, this diagram here, this picture here is from this month's JADA, where they reported, they asked this panel of clinical evaluators to assess the roles of dentists and their dental team in discussing HPV. And they were asked about, providing the vaccine and what they thought the barriers were. And the number one barrier was reimbursement. How are they going to get paid for it? And then preservation. There's very specific guidelines to vaccine handling and storing. So that's also a concern. So, knowing that parents are comfortable with us talking to them about HPV and the vaccine, that really should give us more confidence in taking the leap into having these uncomfortable conversations with our parents or patients. There's multiple strategies that we can use to inform and educate our patients and get the conversation started. So again, I want to point out that we shouldn't be talking about the vaccine as a STI prevention. We should be talking about it as cancer prevention. Other strategies that we could use, we could just have, brochures and posters in our office. And a lot of times these will prompt the patient to ask questions, so we don't have to bring it up first, right? Asking those questions in our medical history, and having prompts built into our electronic dental records that will remind us to talk to patients or parents at specific times. If we know a patient has started the vaccine series, we could be sending them text messages to remind them to get their next dose in the series. But one communication technique that's really very well suited to HPV conversations is motivational interviewing. Hopefully some of you attended Professor Michelle Arnett's presentation on motivational interviewing last week. Or you may have attended other motivational interviewing CE and you know what I'm talking about. But I'm going to give just a very brief overview of MI strategies. And I'll also provide you with resources that you can explore further on your own. But using brief motivational interviewing for HPV discussion should really only take about 3 to 5 minutes of your time. And it's been found to be useful with both parents of adolescents and with adult patients. And it's particularly effective for parents who are hesitant or ambivalent about getting the vaccine for their children. Research exploring the use of MI for HPV conversations has shown that it can strengthen the patient-provider relationship, but also it increases provider confidence in having those conversations with patients. There are 4 principles that guide what's called the spirit of MI. In the spirit of MI, which is shown in this diagram, the provider will have an attitude of acceptance for the patient. So what this means is that you don't have to agree with your patient's choices, and you don't judge them for their choices. You have compassion for them, compassion for their ability to actively prioritize their needs and promote their well-being. And this means making conversations about more about them. So we avoid I statements such as, I think you should vaccinate your child. And the spirit of MI also involves evocation, which is drawing out the patient's own thoughts or ideas, rather than imposing our goals or our expectations on them. So again, avoiding those I statements, asking open-ended questions to find out, what the patient's goals are, what they want to achieve. So when these 4 components are demonstrated by the provider, it builds rapport and trust for the patient-provider relationship, and it'll enhance a patient's autonomy in their own decision-making. So other than the spirit of MI, there are 2 other main strategies that are important to HPV conversations. The first one is ORS, guiding strategies. With ORS, we ask open-ended questions. Those are questions that cannot be answered with yes or no statements. This gives us an opportunity to understand the patient's perception. Affirmations are achieved by giving encouragement and acknowledgement to the patient's strengths. In reflective statements, we repeat back to the patient what we heard them say. So we don't repeat back exactly their words, but what we heard them say in our own words. And what this does is it allows the provider to display an understanding of the patient's perceptions, maybe their ambivalence, and maybe even their efforts to change behavior. It also helps the patient to hear their own statements of thoughts and feelings in a different format. And then with summaries, the purpose of summaries is to close the MI session, to bring closure to it, to ensure that the provider understands the patient's perspectives and connects the information provided by the patient. Then the framework we use when we're educating our patient is called elicit, provide, elicit. And this technique helps us to find out what the patient already knows. So we fill in the gaps. If there's misconceptions, we want to correct those. And we explore how this will fit into the patient's life, what their goals are. This strategy of EPE both validates the patient knowledge, but it also allows time to address any misconceptions or barriers. So the first step is to elicit by posing an open-ended question, such as, what do you know about the human papillomavirus? Or what do you know about the HPV vaccine? By posing an open-ended question, the provider will be able to determine the patient's level of knowledge and understanding. And then what we want to do is to acknowledge and affirm their awareness. The next step is to provide information. So I want you to know first, though, you have to ask permission before you share any information within the MI, within the spirit of MI. And this can be as simple as, may I share some information about HPV and its relationship to throat cancer? And so what this does is it maintains that spirit of MI and allows the patient to maintain their autonomy before you start dumping information on them. The goal is to provide objective, factual information. You're going to be non-judgmental. You want to avoid I statements again. And you also want to be a little careful with you statements. So if you begin with I think or you should, you're not only aligning with the spirit of MI, but your patient's going to close off and not listen to listen to you the rest of the appointment. But after you provide that information, you want to find out what that means to the patient. So what did they hear you say and how did they interpret that information? And then the next step again is to elicit. And you want to elicit the patient's perceptions. Hearing the patient's response will help you as the practitioner to gauge their knowledge, their perceptions, and their readiness to accept the vaccine or not. And it's okay if the patient isn't ready to say, yes, I'm going to vaccinate my child. Remember, it's not really our job to make the patient do something or to fix them. Our goal is to evoke their own motivation for change or for acceptance in getting their child vaccinated. So the framework is EPE, which allows you to apply the OR strategies and then demonstrate the spirit of MI. I wanted to just briefly mention that we've trained our students at the University of Minnesota in how to use MI for HPV conversations. So students have gone through different training modules in HPV and vaccination facts. They've been trained to use brief MI in HPV discussions with patients. And we conducted a study and students reported that they have improved confidence and comfort in discussing HPV with patients using MI. And I will say that they recorded their conversations with patients and they did a great job. They used MI and they were confident, and you could tell that they were comfortable in having those conversations with the patients. So now I want to play 2 audio recordings of Michelle Arnett and I role-playing HPV conversations using MI. The first is with the parent who is receptive to learning more. The second is a 22-year-old patient who is resistant. So we'll listen to the first one first.
In this patient scenario, I am Emily, who presents with her son Bobby for his 6-month prophy. Professor Stahl will be the dental provider. We will demonstrate an elicit, provide, elicit HPV and HPV vaccine conversation utilizing the MI guiding strategies of ORS, which include open questions, affirmations, reflections, and summaries.
Hi, Emily. Thanks for coming in today. Do you have any concerns about Bobby's oral or general health today?
No, not at all. We're here just for his regular 6-month cleaning and checkup.
Great. So, looking at his health history, it shows that Bobby has not yet received the HPV vaccine. What do you know about HPV and the HPV vaccine?
I know that HPV is a sexually transmitted disease, and there's a vaccine for girls to prevent cervical cancer before they're sexually active.
It sounds like you're very knowledgeable about HPV and aware of the HPV vaccine too, as a prevention of cervical cancer in girls.
Yes, I've heard lots about it, but I really don't pay much attention because Bobby is my only child, and the vaccine is not for him since he's a boy.
May I share some information about HPV and throat cancer?
Sure.
Great. The human papillomavirus is very common. In fact, over 90% of all men and women will have HPV at some point in their lives. There's several hundred strains of HPV. Some only cause warts on hands, feet, or in the mouth or genital areas. But there's some strains that can cause several types of cancer, including throat cancer. And this is especially true in men. What do you think about the HPV information you just heard?
I wasn't aware of the link of HPV to throat cancer or how many people are at risk, especially for boys. I thought HPV was only an issue for girls and women.
Sounds like you value Bobby's health, and knowing he may be at risk for an HPV infection concerns you.
Definitely. I have other types of cancers that run in my family. I didn't know that I had to be concerned about throat cancer too.
I'm sorry your family's experienced cancer. May I share some more information to ease your concerns?
Yes, please do.
So most of the time, our bodies fight off the virus before we even know that we have the virus, which is great news. However, there's other times the virus stays in our body for up to 20, even 30 years. And these are the types of HPV that cause cancer, including throat cancer. And often there are no physical symptoms of throat cancer, so people don't even know they have it until the cancer's grown and spread outside of the throat. May I share some information about the vaccine with you?
Are you talking about the vaccine that I see on TV? If so, then yeah, please do.
Yes. When the vaccine was first introduced in 2006, as you stated, it was really only available for girls and only used to prevent cervical cancer. But now it's recommended for boys and girls between the ages of 9 and 26, and even some adults up to age 45. The FDA has found that it's safe and effective against 9 different types of HPV, and those would include types that cause warts and types that cause cancer. Research has shown that it is very effective against cervical cancer and the types of HPV that cause throat cancer. What are your thoughts regarding the HPV vaccine after hearing that information?
I didn't know that Bobby was at risk or that he was even eligible for a vaccine to prevent him against HPV. I really would like Bobby to be protected.
So you were already knowledgeable about HPV and the vaccine for girls, but it sounds like you were surprised to hear that Bobby is also at risk and can be protected with the HPV vaccine.
That's right. So what do I do now? Do I have to talk to his primary care doctor?
Yeah, that's right. So following up with your primary care doctor is the best way to get the vaccine. Would it be okay with you if I checked in with you at Bobby's next 6-month checkup about his vaccination status?
Yes, please do.
Great. Let's get started with Bobby's checkup.
In this patient scenario, I am Emily, who presents with her son Bobby for his 6-month prophy. Professor.
Okay. So now we'll look at a patient who is resistant. And for those patients who are resistant, it's important to use the rules principles. resist the writing reflex. This means we do not fix or change the patient's behavior. If you try to fix your patient or offer advice without permission, this can impair the inpatient from making their own decision and impair your relationship as well. So as a provider, you want to demonstrate that you understand the patient's motivations, their perceptions of change or perceptions of challenges associated with change. And when a provider has a better understanding of what motivates the patient, they are more likely to provide support and demonstrate acceptance for the challenges that the patient may face. Listening with empathy is the next rule. And this aligns with the spirit of the MI. And it's always a good reminder that empathy is not pity. We're not going to pity our patients. Lastly is E for empower. The goal of MI is to support patient autonomy and build their own self-efficacy for change. So let's listen to how we can use MI for patients who are resistant to hearing about the HPV vaccine.
In the second scenario, we will demonstrate how to roll with resistance. During motivational interviewing conversations, you must resist the writing reflex and not impose your goals, values, or ideas onto the patient. These rules should always be applied. However, when patients do not want to discuss behavior change or sensitive topics such as HPV and HPV vaccine, it is even more important to follow these rules. Professor Stahl will be the 22-year-old female patient, Carrie, and I will be the provider in this role play scenario.
Hey, Michelle. I noticed a poster in your waiting room about the HPV vaccine. Why in the world are dentists concerned about the HPV vaccine?
That's a great question, Carrie. There's a link between HPV and throat cancer. So the School of Dentistry is spreading awareness.
I don't know about that. I heard that HPV only causes cervical cancer in women.
Yes, you are correct. That is one form of cancer from HPV. May I share some information on other cancer from HPV and oral risks with you?
I don't know. I've heard about what the risks are. I'm engaged to my high school sweetheart. We're committed to each other, and we're not really at risk. I'm not interested in that vaccine or any other for that matter.
Many people feel the same way as you do, Carrie. If you ever want information, you can contact me or anyone here at the office. Is it okay if we get started with your dental appointment now?
Yeah, that'd be great. Thank you.
In the second scenario, we will demonstrate how to roll with resistance. During motivational.
So that's it. So you can see that, with patients who are resistant, we don't need to force them to do anything, and it may take some time for them. But having, posters up and brochures out and having a pro HPV vaccine environment may help them to come to some decision at some point that they are ready to start exploring that. So hopefully that gave you an idea of how to apply MI to HPV conversations. It's important to understand that learning MI does take time. You won't all go back to your practices now and feel comfortable having these conversations. Allow yourself some time to practice, role play with each other in the office, and maybe start out with just a strategy that you feel most comfortable with. Maybe if it's a poster or two, if that's what you feel comfortable with, start off with that. Here is a list of videos and other resources for dental providers. This is in one of your handouts. And then some motivational interviewing resources. And then if anybody, I've got some references here as well. If anybody wants those, I would be willing to share those also. And that is it. Thank you. Are there any questions? Let's see if I can get to the... Okay. So the first question is, for same partner will still be at risk of any HPV cancers? I'm not sure what you're asking there. If you've had the same partner, a lifetime partner, then maybe not. No, you wouldn't. You'd be at least at risk. If I'm not answering that right, please let me know. If the last dose was missed, the patient would need all the doses again. No, I don't think so. I think they can pick up some. There have been some studies that have shown, and in fact, the Costa Rica study has shown that there may be they may be effective with just one dose. There's some effectiveness there. Can the vaccine administered in the dental clinic or have it to be by the primary provider? So for most states, yes, it would be by the primary provider because dentists are not authorized in most states. However, like in Oregon, they are authorized to give the HPV vaccine. Yes, HPV is now, or oral pharyngeal cancer is now the most common type of oral cancer because there's been a decrease in the rates of oral cancer as opposed to the increase in oral pharyngeal cancer. I don't know the cost of vaccination. I'm sorry about that. Can you discuss timing of the screening in light of probable changes, oh gosh, in infection control, especially in relation to gloving? I'm going to say I don't really know yet since we don't really have all of our infection control policies in place right now. Best age for HPV vaccines is between the ages of 11 and 12 when their immune systems are strongest. Boy, all these questions coming in. How do you defend yourself against dental boards that reprimand dentists for discussing HPV with patients? I had no idea that was going on. With the support that we have from ADA and the American Academy of Pediatric Dentistry, I would say that we need to use that as our defense there. They're asking us to talk about this with our patients. In fact, you can get HPV brochures from the ADA. Charge code for the vaccine, that would be a medical code. It would not be a dental code. There is not a dental code yet for the vaccine. You suggested sending patient text. What about HIPAA? What text consent do you utilize, which I believe is required prior to texting? Yeah, you would have to get consent from your patient to text them. Do the U of M clinics have a question on the medical history regarding HPV immunization? Yes, we do. We don't have any questions yet about some of the risk factors or the signs and symptoms, but we do have a question on HPV vaccination. If we are having an initial discussion with a parent in the room with their preteen child and maybe even a younger sibling, and the parent is confusing how an STI is causing cancer in the mouth, how would we go about explaining to them the correlation given their children are in the room without it becoming awkward? So I think we just, again, focus on it as being more of a cancer prevention. If the parent wants to talk about it, the sexual risks, then I would suggest that probably you would take the parent off in another area to talk about that. But again, I would hand them a brochure, have them look at it. They can read it. If they want to ask you some questions, then it should not be in front of their child. And then have that conversation somewhere else. What is the efficacy of the vaccine after 26 years old? So it depends on whether or not the patient has been exposed to the vaccine types. If the patient has not been exposed to it, or if their immune system has cleared it, it is efficacious, as was shown in the Costa Rica study. But if the patient already has has been exposed to the vaccine or the the virus, then it probably is not as effective. But again, it depends on what the risk factors are for the patient. So some adults who may be at higher risk would be the patients who their physicians may recommend it for. And again, that's a conversation that you have the medical provider has to have with their patient. Are there possibilities for false positives to HPV testing? I have not, nothing I've read says anything about a false positive to HPV testing. That, I'm sorry, I can't answer that question very, very clearly. I just have never heard about false tests. Can you talk about recommendations for ages 27 to 45? Again, I think that's a recommendation, or that's a conversation to just make them aware of it, that it is available, and then to refer them to their primary care physician. Aren't we opening ourselves up to lawsuits by adding the examination of the oral pharynx, since it really is not possible in the dental office? Actually, I've been talking to an ENT, and the ENT thinks that it can be done in a dental office. In particular, if we're trained appropriately. And there are other speakers across the nation that are talking about this. I don't know if you guys have heard of the Cotton technique, but Susan Cotton in Colorado has developed a technique where what she calls the enhanced oral pharyngeal, or enhanced head and neck exam, oral cancer exam. And she talks about, palpating back in the oral pharyngeal area as well, and using the oral camera, the intraoral camera. That picture that I had of the base of the tongue and the epiglottis was from the Oral Cancer Awareness website. Can you talk about when Gardasil was previously taken off the market? I'm sorry, Deanne, I don't know anything about that. Sorry. The Gardasil 9-shot schedule, if a patient's schedule did not allow for 1 to 2 or 6 months exactly, should they? It shouldn't be before 5 months from the first dose, but it can be up to 12 months afterwards. So, and again, some studies have shown immunogenicity with just 1 dose. So I think most physicians would say that if it's late, you can go ahead and give it even later than that. They just don't want it before the 6 month or the 5 months between the first 2 doses. Okay. Any other questions? I have had adult patients ask about the vaccine. Should I just refer to the MD? Yeah, I mean, Dr. Gross, you could probably tell them that the vaccine is available for them, but that they should talk to their doctors about it, because of the efficacy of it. It really is a case-by-case basis with that. But talking to your adult patients about, the risk factors and what to look for also would be very important with those patients. Should we be doing, yes, I believe that you should be doing IOEO exams with pedo patients. Mm-hmm. Any other questions? All right. Well, I guess that's it then. Thank you very much, everyone, for joining me on such a lovely evening. and let me know if there's, Dr. Joe Peterson can give you my email address, and let me know if you have any questions. I'm open to answering emails from you. So thank you. Got one more question, I think. Oh, thank you. All right. Thank you, everyone. Bye.